This module introduces the need and in many specific ways attempts to demonstrate the continuum of care we can provide as part of care, treatment and support initiatives for people living with and affected by HIV. The model also attempts to trace the manner in which the response was shaped by and evolved from people's need rather than one that was guided by projects and programs. And finally, the model also seeks to highlight the importance of coordination and cooperation between individuals, families, communities, and services in order to achieve the optimum level of HIV care.
The continuum of care is not something new, but is intrinsic to any disease that is chronic in nature. HIV is a lifelong infection with no sight of a cure. People living with HIV have to deal with and cope with changing needs that are emotional, spiritual, physical, and medical, and additionally have to bear the burden of stigma and discrimination that they are often faced with.
To begin with, the module will focus on the programmatic commitments made in NACP 3. Later, we will examine the commitments made both in terms of resources allocated and the directions it has laid down on the continuum of care and support. We will then do a reality check and see to what extent the Bagalkot demonstration project conceived the continuum of care and support and what did they achieve in terms of integration from prevention to care and support.
The National AIDS Control Program Phase 3 emphasizes the need for integrated prevention, care, treatment and support program at the district level. For the first time since 1986, this program allocates a substantial proportion of budget towards not only prevention for the 99.7% of our population that need the prevention services, but also allocates a proportion of their budget for HIV care for that 0.3% who are estimated to have already been infected. The National AIDS Control Program Phase 3 clearly positions the integrated counseling and testing centers as not merely prevention services for general populations and high-risk groups, but also as the entry point to the HIV care. Prevention programs themselves have gone beyond the blood safety issues, the targeted interventions, and the STD clinics to also address rural populations, clearly recognizing that HIV has invaded into rural areas. So treatment, care and support interventions have now gone beyond the low-cost community-based care model, which only looked at terminal care and end-of-life care, to also address issues related to tuberculosis, which was the commonest cause of death, as well as antiretroviral therapy through which quality of life and the duration of life could be improved. Our approach has been to try and optimize the impact of the continuum of care in order to trace loss to follow-up at every level. We'd like to reduce the loss to follow-up between the time of diagnosis and their registration into the ART centers, from the ART centers to the networks of positive people and the community care centers to ensure the continuum of care. And ultimately, we would like to ensure that deaths and morbidity related to HIV are reduced.
Let us do a reality check. Let us take a look at the experience that we gained in Bagalkot. Let us explore to what extent these programmatic formulations were translated into practice on the ground.
In Bagalkot, we began with what we knew and what we could do. In communities, HIV was already prevalent, and people responded in the way that they knew best by isolating those who were affected by the disease into dark and lonely huts, through the doors of which food and water were pushed in.
One of the key responsibilities of the link worker was to reduce the unacceptable levels of stigma and discrimination. For instance, in village Kadlimatti, Macha, the link worker, tried to convince the family of Nagappa, who was living with HIV/AIDS, to take care of her 2 daughters. Her family was reluctant to take care of the children due to fear of being infected with HIV. One of the children was also HIV positive and died soon after. When Nagappa's younger brother came to the hospital to take the children, He saw Macha sharing food and taking care of the children without any hesitation. He shared this matter with his other family members. This helped Macha to remove the stigma amongst the family members and the villagers as well.
Our link workers, by just sharing a meal with them and their water, dispelled this myth that HIV was a contagious disease.
Having gained the confidence of the community and village elders, the link worker became the integral part of care and support services. This translated into many supportive practices.
Support group meetings brought people together, and they realized that they were not alone in this fight against HIV. The medical services, the nutritional supplementation, the opportunistic infection management, and the linkage to antiretroviral therapy helped to build this continuum of care over time.
It is clear that with every passing year since 2006, the service component expanded at the district level.
In the early phase, the only service component available in Bagalkot was Jeevan Jyoti. The link worker would do exhaustive counseling of the PLHIV and motivate them to attend the Jeevan Jyoti outreach clinics. By end of 2006, the service component expanded and we had a full-fledged ART center in Bagalkot. Even before the rollout of ART services in the district, there was a robust referral system established by the link worker. The link worker would identify the target population in the community, which are the people living with HIV, TB suspects, and most at risk population, and would appropriately refer them to service points, which may be PHCs, the district hospital, or the TB services. The comprehensive services provided at Jeevan Jyoti outreach clinics included psychosocial support, opportunistic infection management, nutritional support, and a whole lot of social entitlements. Before the ART center was rolled out at Bagalkot district, people would have to go to Hubli for ART. Once the ART center started in Bagalkot in 2006, the primary referral of the link worker was to the ART center for pre-ART registration and CD4 testing. With this, PLHIV could access a whole gamut of services which are available at both Jeevan Jyoti clinics as well as the ART center. PLHIV would then be followed up in the field as to whether they are started on ART and followed also on the ART adherence. Once a sufficient rapport was built up with the PLHIV, inquiry would be made into the status of his spouse and his children, and they would be also appropriately referred. Any home-based care services which were required by the PLHIV in the field would be addressed by the link worker with the available services at the sub-center and at the PHC. If the PLHIV is sick of opportunistic infections, a referral would also be given to the community care center, which is at Bagalkot and at Jamkhandi taluks. The second important target of the link worker in the community was most at-risk population. This population comprised of men and women with high-risk behavior, people living with HIV and their spouses, and the spouses of those who were engaged in high-risk behavior. Most at-risk population were referred to the STI clinics in the selected villages. A cross-referral would also be given for testing services available at the VCPC. Those most at-risk population who were detected to have HIV would appropriately be referred for ART services as well as to the comprehensive services available at Jeevan Jyoti outreach clinics. The link worker would mobilize positive pregnant women in large numbers to avail PPTCT services available at the district and taluka hospitals. Those pregnant women would disclose their status to the link worker, were referred for services at the ART center. Those positive pregnant women who were not eligible for ART and were not started on ART by the ART center, the link worker would then follow them up extensively in the field and would assist for nevirapine prophylaxis to the mother-baby pair at the time of delivery. The mother-baby pair were followed up till 18 months of age, and testing of the infant was encouraged at 18 months of age. If the infant was found to be positive, the link worker would assist the pair to avail comprehensive services available at the PPTCT and at the ART center.
Every district in Karnataka now has at least one ART center at the district hospital or medical college, and Bagalkot is one of them. Bagalkot has the largest number of individuals registered at a district hospital level ART center, indicative of the growing burden of HIV in this district. It is the only district in the state where every one of the 6 talukas has been approved to have a Link ART center. Keeping PLHIV at the center of interventions is essential to any care, treatment and support program. Psychosocial needs and psychological well-being comes up as the foremost priority, and hence our attempt was to improve both the numbers and the quality of HIV care counseling. Medical services are the second need, and the itinerant services offered through Jeevan Jyoti, complemented by the inpatient care at Arunodaya and other community care centers, support the ART offered at the district hospital. The attempts made at nutrition interventions are minimalistic, and more needs to be done in this area. Positive prevention through condom promotion and STI screening and treatment have been given attention. Linkage to educational and vocational services, referrals to other social sector services, and advocacy with departments support livelihood options, and finally, home-based care is offered to the small proportion of those too sick to travel to a facility for care.
At the community level, link workers are the primary caregivers in all villages where HIV is concentrated. Where HIV-infected people are few and far dispersed, the local A&M or the Anganwadi worker and ASHA take on this added responsibility of education, basic service provision and referral to an HIV care center. Peer outreach workers from Jeevan Jyoti and the community care centers are responsible for tracking loss to follow-up, community mobilization, organization of medical and other service delivery, and addressing stigma and discrimination within rural and urban areas at the taluka level. To get a more long-term view on the continuum of care and support, we need to look at the IMAI approach and assess its significance and importance.
It was in 2006 that the WHO's or the World Health Organization's IMAI approach, or the Integrated Management of Adolescent and Adult Illness, brought in the element of not just assessing, agreeing and advising, but also moved into elements of assisting and arranging for HIV care. From a stage of only symptom-related management of people living with HIV and AIDS, people now began to look more comprehensively at the overall medical needs. Assessing for family status, looking at family planning and reproductive health needs, looking at tuberculosis screening and treatment, and readiness for antiretroviral therapy and adherence thereafter. From a stage of only symptom-related management of people living with HIV/AIDS, people now began to look more comprehensively at the overall medical needs. It is the IMAI approach that helped us to understand different interventions are required at different stages of HIV illness. At the stage of HIV diagnosis, it is important to deal with psychosocial behaviors, to deal with preventive behaviors, and to deal with health-seeking behaviors. Later in the disease, it is important to look at nutrition interventions and the treatment of opportunistic infections. In clinical stage 3 and 4, it would be important to not only treat infections, but to also prevent the most common opportunistic infections. Antiretroviral therapy gets introduced at this stage, and nutrition interventions need to be more intensive. Even in the last stages of HIV, measures to address bereavement, to look after children orphaned and vulnerable as a result of HIV, and to address social security concerns of people living with HIV and their families remain a challenge. Throughout the stages of illness, legal support, socio-economic support, nutrition support, and measures to address the children need to be looked into. Thus, the IMAI approach did help us to prioritize interventions according to the stage of illness that an individual goes through. The care treatment support initiatives demand a continuum in capacity building initiatives. Thus, the IMA approach is used as the induction module where the doctor, nurse, and counselor come together to be trained using the expert patient trainer method. Beyond the induction training, clinical mentorship of teams of doctors, nurses, and counselors is provided on site at the community care centers and drop-in centers. The Samastha HIV e-learning package or the online website, or what is commonly referred to as the Samastha Help, aims to keep doctors updated with the rapid medical advances. Learning sites provide the opportunity for hands-on experiential learning and also help us to develop protocols required for admission, discharge, or death of patients. In conclusion, we would acknowledge that yes, ART centers do provide the life-saving ART, which helps us to add years to life, improving the duration of life. It is the community care centers that provide the care, treatment, and support that help to add quality to life. And it is the drop-in centers or the integrated positive prevention and care centers that help each person to support the other, thus adding quality to lives. We hope that our journey with you over the next few days will help you discover this continuum of care within the district through the different services and community initiatives that have been going on in Bagalkot since the last 5 years. Thank you.